This program is brought to you by Emory University.
Good morning, everyone. Happy Friday. This morning we have a journal club presented by Melroy D'Souza and Jeff Wang. We are lucky to have both of them here as third-year fellows. Melroy came to us for residency from New Jersey, stayed here. He was here for Emory residency and then fellowship, and will be staying on next year at St. Joe's. Jeff came to us from Hopkins residency. He was at LSU for medical school and will be staying in the Atlanta area to be a critical care physician. And we are very critical cardiology, I should say, physician. And we are really welcome to have them both this morning talking about some important topics for us. So take it away, Melroy.
Okay, good morning, everybody. Happy Friday the 13th, and thanks for joining today. So for my part of Journal Club, I wanted to talk about a trial that was published at or presented at AHA recently called the CLEAR trial, which looks at the use of spironolactone in the setting of an acute MI and its impact on outcomes that we'll talk about. So, the trial is not too complex by itself, but I think the context and the background leading up to the trial question is sort of important. So we'll spend a lot of time talking about the history. But the main question is, does aldosterone antagonism, particularly with spironolactone after MI, in patients who either have preserved EF or don't clinically have heart failure, does spironolactone actually improve their outcomes? So the background, many years ago, sort of in the 80s and 90s, more and more was being developed about the RAS system, and particularly what happens after myocardial infarction. And we know that on the myocardial level, RAS is activated when there's local ischemia and infarction, and then that also leads to impacts on the kidneys, and then systemically the RAS is activated and hormones are secreted. Particularly, we think about angiotensin II and aldosterone as having the primary effects of RAS. And there's a whole variety of different molecular mechanisms and downstream impacts of angiotensin and aldosterone. But the ones that we care about is, of course, the induction of fibrosis, which also has by itself several different mechanisms. And in the setting of ischemia, I think the other main mechanism was sort of changing the balance of bradykinin secretion and endothelin. Bradykinin, which primarily works as a vasodilator, endothelin, which works as a vasoconstrictor. When RAS is activated, maybe endothelin tips the scales a bit more, which can be maladaptive. So, these hormones gained interest in terms of cardiac remodeling and adverse cardiac effects. So that's why aldosterone became a key player. There was actually a trial fairly early in the decade that looked at when patients who had MIs checking their aldosterone level fairly soon in their clinical course, does the sort of magnitude of aldosterone secretion have an impact on outcomes? So what they did, fairly small study, they took about 350 patients, checked aldosterone at the time of cath. So they put the sheath in and checked the blood sample from the sheath. And what they did is they sort of divided the patients into 4 different quartiles, 1, 2, 3, 4, and the patients in each quartile had varying levels of aldosterone, from 1 being the lowest and 4 being the highest. And then they looked at in each quartile, well, how did those patients do for either in-hospital mortality, recurrent MI, progression to heart failure, cardiac arrest, or ventricular arrhythmias. The characteristics of the patients, small trial, but I think maybe fairly representative of those who we see presenting with MIs. 20% were 75 years or older, 20% had prior MI, 14% had prior revascularization, about 40% had an anterior MI, and 5% presented with shock. In this trial, almost everybody got a bare metal stent. This is back in 2006, which, we'll come back to later. And this is sort of the main graph of the trial. And just to orient you, so for each variable, they reported the different quartiles. So again, each of them, you'll see sort of 4 bars here. Bar 1 is quartile 1, the 4th bar is quartile 4, and those in quartile 4 have the highest amounts of aldosterone that they found in the serum. Quartile 3 a little bit less, 2 a little bit less, 1 was the least. And as you can see, for several different outcomes, quartile 4 compared to quartile 1, those patients had significantly worse outcomes. And the ones to note are all-cause death and cardiovascular death, significantly worse outcomes for those with higher aldosterone levels. And then other factors were new or worsening heart failure was a significant difference. Ventricular fibrillation was significant. VT was not. And then resuscitated cardiac arrest, those with the highest levels of aldosterone did the worst. Okay. And this is sort of just breaking down the cumulative survival for those patients by quartile. As you can see, quartile 1, which were the lowest aldosterone level patients, did the best in terms of survival, whereas quartile 4 did the worst. So then the conclusions of this trial, they said, well, we think with those patients who present in acute MI, maybe the level of aldosterone can sort of risk stratify them further and increase their risk for adverse outcomes. And then, they sort of gave a hint that the deleterious effects of aldosterone, again, with cardiac remodeling, fibrosis, changes in sort of vascular dynamics, it sort of proved what we suspected was that aldosterone can have negative effects. So then the question is, again, at the time of MI, if we block the effects of aldosterone, can we actually have better outcomes for those patients with MI? So there's what the rest of this talk will focus on. Particularly the aldosterone antagonists that we'll talk about is spironolactone and eplerenone. I think there's an RV formulation called potassium caronate, which one of these studies use, but the oral agents are primarily the ones that we're familiar with. And I think any talk about aldosterone has to talk about the RAILS study, which is not in MI, but RAILS really what they did was they take patients with severe systolic dysfunction, so about EF of 25%. And they randomized them to receiving spironolactone or placebo. All these patients had New York Heart Association class 3 or 4 heart failure. They were about 50-50 ischemic and non-ischemics. And again, the study was in 1999. So those patients that, sort of medications that they were on that time, all patients were on diuretics, most were on ACE inhibitors and digoxin. So sort of pre-4 pillar GDMT era. What they saw, they took 1,600 patients, about half of them received spironolactone. They actually stopped the trial at the halfway point, which I think was about a year and a half in, and it was supposed to be about a 3-year trial because the benefits were so clear. There was a mortality decrease in those who got spironolactone. The death from cardiac causes was improved in those in the spironolactone group, and so was the cardiac hospitalizations. So this study really sort of put spironolactone on the map and, made spironolactone sort of a pillar for heart failure therapy. And when they looked at mortality compared to placebo, spironolactone patients did better. One sort of humbling perspective for me, as a young trainee, was looking at sort of mortality in 1999 for those with heart failure. Even the spironolactone group, this new drug not a new drug, but this drug with new impacts for those with heart failure at 24 months, like patients did better than placebo. But even then, their survival was only 70% compared to these days. I think, even with some levels of GDMT, survival is still about 80-85%. So, I think we've come a long way in the last 2 decades with our ways of managing heart failure, and patients are clearly doing better. But, RAILS certainly showed that spironolactone improved outcomes for patients with severe systolic dysfunction and clinical signs of heart failure. So aldosterone was sort of promising there. Now, kind of going upstream, half of those patients developed heart failure because of MIs. So, can we use aldosterone early in the setting of ischemia to help patients, not progress to heart failure? Then there was a Ephesus trial, which was in 2003, and they used eplerenone. And what they did was they looked at those who had heart failure or those who had MIs and developed clinical heart failure. So either, there was an echo that showed that their EF was under 40%, or they had clinical signs of heart failure. The one caveat was that patients with diabetes, as long as they had an EF that was under 40% and they didn't exhibit any signs of heart failure, they were still enrolled in this trial, just because patients with diabetes are known to have such bad outcomes and bad comorbidities. The outcomes of interest for the Ephesus trial was time to death, time to cardiovascular death, or time to cardiovascular hospitalizations. And they used spironolactone at an initial starting dose of 25, and the target dose for the trial was 15 milligrams. So fairly large trial, 6,600 patients were enrolled across 36 countries. About half received eplerenone, half were on placebo. sort of baseline GDMT medications, both from an ischemia perspective and from a heart failure perspective. Most were on aspirin. About 3/4 were on beta blockers. 87% were on either ACE and ARB, and then about 60% of patients were on diuretic. The mean EF for the trial was about 33%. So not all kind of met that severe cardiomyopathy cutoff, systolic dysfunction cutoff, but fairly low EFs and with clinical signs of heart failure. About half of patients post-MI got revascularized or reperfused, and 90% of patients demonstrated clinical signs of heart failure. So sort of busy summary table of the results, but big takeaways were that death from any cause or death from cardiovascular causes or hospitalizations were significantly better in the patients in the eplerenone group or the aldosterone antagonist group. And then looking at sort of the components of the composite outcomes, so separating out death from any cause or any hospitalizations, death from cardiovascular causes or sudden death from cardiovascular causes, all of those outcomes were better in the eplerenone group. Some other variables that they looked at, did not have a significant difference, but the very hard outcomes of death or hospitalizations were improved with the eplerenone group. And then, maybe not surprisingly, any hospitalizations for either heart failure were improved in the eplerenone group, as we know that those with systolic dysfunction and heart failure do better with aldosterone antagonism. So, and then this was just some other curves. The top one demonstrating death from any cause, the middle one demonstrating death from cardiovascular causes, and the bottom one demonstrating rate of cardiovascular rate of sudden death from cardiovascular causes. And the large takeaway, they were all significantly improved for those patients in the eplerenone group. So overall, he just told us that those in the subacute phase, sort of that 3 to 14-day phase post-MI, aldosterone antagonism in patients who develop systolic dysfunction or clinical heart failure, aldosterone antagonism for those patients improved outcomes. So, I think Rails showed us that patients with systolic dysfunction do better with spironolactone. He just showed us that post-MI, those with systolic dysfunction and heart failure did better with eplerenone. But what about those patients post-MI who have either preserved EF or don't have any clinical signs of heart failure? To try to answer that question, there was a reminder trial. This is in the European Heart Journal in 2014, and they randomized patients presenting with a STEMI to receive either eplerenone or placebo plus standard therapy. Those patients could either not have any signs of heart failure, or they had to have an EF of over 40%, which is in that sort of mild reduction range or relatively preserved range. The composite outcome for reminder was cardiovascular death, heart failure hospitalizations, ventricular arrhythmias, a drop in EF, and then a BNP over a threshold. And they either use BNP over 200 or they use NT-proBNP, which was stratified by age. And you could see the cutoffs that they used here. So Reminder actually was positive for their composite outcome. So they saw that patients who were in the eplerenone group, they had a hazard ratio of 0.589. So there was about a 40-ish% reduction of this primary endpoint in those who received eplerenone. It was very significant. Interestingly, though, when they broke it down, so they broke down the primary composite outcome to the individual components, the only thing that was significantly different between the two groups was that BNP levels were lower in the eplerenone group compared to placebo. However, the other components, cardiovascular mortality, rehospitalizations, ventricular arrhythmias, drop in EF, those were all non-significantly different between eplerenone and placebo. So just this improvement in BNP seemed to be driving that benefit and positive outcome. And then there's some secondary endpoints too that were all non-significant. So, sort of an interesting aspect there. So then after a reminder, which was a positive trial, but maybe just improvement in BNP, there was the Albatross trial, 2016, a couple of years later, and they randomized sort of all MI patients, STEMI and non-STEMI, to receive mineralocorticoid receptor antagonist or placebo. The MRA group initially, sort of very early on in their hospital course, received an infusion of potassium carinoate, which is an IV aldosterone antagonist. And then about 12 to 24 hours later, as long as their labs were okay, then they got spironolactone, and they were followed for 6 months. Composite outcome here was death, cardiac arrest, ventricular arrhythmias, having a class 1A indication for ICD, new or worsening heart failure. And secondary outcomes were some different combinations of the primary outcome, recurrent MI or unplanned revascularizations. Primarily STEMI patients, about 77%, 90% received PCI, and EF was low normal or to be normal here in albatross. And this was a negative study. So they found in their primary outcome, there was no difference in those that received spironolactone compared to placebo as a ratio of, almost nearly 1 and p-value of 0.81. And when they broke down the individual components of the primary outcome, as you could quickly see here, that there was no really difference between the two groups. So with STEMI plus or NSTEMI patients with no heart failure, preserved EF, they didn't seem to do better with spironolactone. However, there was so the top curve here is mortality for all patients, but in the bottom curve here, which I'll blow up, this is actually looking at only specific patients with STEMI. They actually had a mortality benefit in the spironolactone group. So, that has a ratio of 0.2, quite low, and that was significant. So the albatross trial, although their primary outcome was negative, when they looked at specifically those patients with STEMI, they seemed to have a mortality benefit. And then, so they went back and they kind of delineated their outcomes from STEMI in the setting of STEMI only and NSTEMI, and the all-cause death was significantly different in the STEMI group, right here. So the takeaways from albatross was there's no benefit in acute MI when you look at all comers, but if you sort of stratify for STEMI patients, they seem to have a mortality benefit, which then sets the scene finally for our trial here, which is the CLEAR trial of the routine use of spironolactone in acute MI with the particular eye on STEMI patients. So CLEAR was actually a 2x2 design because they were not only looking at spironolactone in STEMI patients, they were actually looking at using colchicine as well as part of sort of the CLEAR synergy group. That was presented earlier, and that was a negative trial. But for this sort of analysis, we'll focus on the spironolactone arm. It was international, prospective, double-blinded, placebo-controlled trial. They planned on only analyzing patients with STEMI or enrolling patients with STEMI, but to sort of increase their recruitment to help their N number, they included some patients with NSTEMI too, as long as they had some risk factors. And those risk factors were the patients had diabetes, if they were older, over 60, if they had multivessel disease, thing defined as greater than 50% stenosis in a non-culprit artery, or if they had an EF sort of at a borderline EF, still be sort of preserved, but in only that moderate group at 45%. But again, mostly STEMI, because that's the question that we need to answer. The prior question was already answered. PICO, really quick. The patients were patients primarily who presented with STEMI, but some non-STEMI patients. The intervention group received spironolactone, 25 milligrams plus standard therapy. The comparison group got placebo plus standard therapy. And the outcome of interest was a composite of cardiovascular death and neuro-worsening heart failure. It was a composite of also time to recurrent MI, cardiovascular death, or heart failure on a time to event analysis. And a secondary outcome was neuro-worsening heart failure, ventricular arrhythmias, or cardiovascular death. The exclusion criteria for CLEAR is that the patients were hypotensive to start, or maybe exhibiting signs of cardiogenic shock. If they were breastfeeding or they were currently pregnant, the creatinine clearance was under 30 to start. If they had cirrhosis or if they had a need for spironolactone from another indication, for cirrhosis, then, they wouldn't put them in the groups in case they need to randomize them to placebo. So those patients were excluded. And the safety outcomes they looked for was hyperkalemia, which they defined as over 5.5, death from renal causes, or progression to dialysis. The sample size, so they sort of, determined that if they had 546 sort of events in the group, that would maybe demonstrate a 25% relative risk reduction, which they thought would be significant. So to get to that number, which is sort of can't really wrap my head around, but their target enrollment size was 77,000% to be able to detect a significant difference. So, they got about 7,000 patients across 14 countries and over 100 centers. The median time to randomization, so I think, when the patient came into care and the time that they met all the inclusion criteria and got randomized was about 26 hours. And then from randomization to first dose of trial drug was 2 hours. The median follow-up for these patients were 3 years. So, that's longer than these prior trials have looked at these patients. So that was exciting to see. But weirdly, that almost 30% of patients in the spironolactone group discontinued the trial drug, and 25% patients in the placebo group discontinued the trial drug. This is table 1, just comparing the baseline statistics of all the patients. As you can see, fairly well matched. I think as we write about, and justifiably so, predominantly men enrolled in this trial. In this case, predominantly patients were enrolled in Europe, but maybe a better sampling than some of our other trials that we had. And then some clinical characteristics to care about. So the KILIP class is sort of kind of grade on 1, 2, 3, 4, and it's about heart failure, clinical heart failure presentations. So KILIP class 1 is absolutely no heart failure symptoms. 2 is mild symptoms, maybe the BNP is up. 3 is they have signs of volume overload, pulmonary edema, and class 4 is cardiogenic shock. So again, this trial is to try to look for patients with preserved systolic function or no clinical signs of heart failure. So those with signs of heart failure, which is class 2 or more, there was less than 1% of patients in both groups that had signs of heart failure, which is sort of the target here. And then STEMI, which is the primary population that was of interest for the study, 95% patients in both groups presented with STEMI. So, hopefully we can interpret these results to say that this is a primarily STEMI population. And this is just going into their medical history. Sort of getting close on time, so I won't spend too much time here. But, in terms of intervention, we looked at that initial study that was done in 2006 that was primarily bare metal stents. But of course, now in this era, patients primarily got drug-eluting stents, which might impact their outcomes, as we'll talk about. So results, this is also a negative trial. So this is table 2, sort of like talking about the different components of the primary outcome and the components of the primary outcome. So as you can see, death from cardiovascular causes or new or worsening heart failure, the hazard ratio was 0.9, which was not significant. Death from cardiovascular causes, UMI, stroke, new or worsening heart failure, hazard ratio was very close to 1, so of course not significant. And the components of the primary outcome, so death, cardiovascular cause, recurrent MI, stroke, heart failure, all by itself. The top 3 were very close to 1 or over 1. New or worsening heart failure was maybe the best hazard ratio with this 23% reduction, but it was not significant from the spironolactone group compared to the placebo group. And then some secondary outcomes for death or clinically significant arrhythmias were no different. And then for safety outcomes, for those who received spironolactone, again, they had similar profiles and adverse events compared to those of placebo. So it's not like the spironolactone group had a higher number of death from renal causes or progression to dialysis. So at least spironolactone seemed safe in this group. This is sort of looking at the curves for the cumulative incidence, for specifically death from cardiovascular causes or new or worsening heart failure, which is sort of that very first primary outcome. As you can see, the curves don't separate at all, and the hazard ratio is 0.9. And then, different composite of death from cardiovascular causes, blah, blah, blah. The curves do not separate here. Looking at adverse events, the things to note, hyperkalemia was higher in the spironolactone group, as you would imagine. Breast tenderness, gynecomastia was also higher and significantly higher in the spironolactone group, which is not surprising, but at least orthostasis and hypotension seem to be no different between the 2 groups. So spironolactone did not show an improvement in mortality or cardiovascular events such as hospitalizations or recurrent MI or stroke compared to placebo, even in a primary STEMI population, as was maybe hoped for after Albatross. So, another negative trial showing that spironolactone and acute MI without heart failure does not necessarily improve outcomes. So, why is this? That initial study that we talked about, those patients primarily received bare metal stents, and they had sort of improved outcomes when they used aldosterone antagonism, but they also had clinical heart failure. So, maybe just our time to intervention, our types of intervention, our stents being drug-eluting stents, all of that is impacting outcomes. As we know, they impact outcomes for the better. So maybe is that why we're seeing sort of negative effects of aldosterone antagonism? That's one thought. My other thought was that, we know from the studies that looked at aldosterone levels in patients with acute MI, we know that higher aldosterone levels, those patients did worse, particularly with heart failure. And, my question is this the chicken or the egg sort of issue? Because this initial study was alluding to the fact that, with ischemia, maybe some infarction, activating RAS, and then secreting aldosterone, that leads to all of these worsened outcomes. Well, what if the actual order of events is that there's ischemia infarction significant enough to cause clinical heart failure, and then we know that cascade of heart failure ramps up the RAS, and then we're seeing aldosterone levels going up really high when heart failure is already present, as opposed to aldosterone causing the eventual transition to heart failure. So, maybe that chicken or the egg order of events makes the fact that, hey, if heart failure is not already an issue, systolic dysfunction has not already developed, then, perhaps the RAS system is not as ramped up as we initially thought. Therefore, aldosterone blockade does not really help. The limitations of CLEAR, there was a lower incidence of events than the authors initially expected. So they could say, maybe that leads to a type 2 error, which says that there's a falsely negative overall result. Rate of discontinuation, particularly in the spironolactone group, was higher than expected. So again, maybe trending towards a false negative. And then similar to a lot of our large trials, women and some racial groups were underrepresented. So the takeaway for right now, with all the information that we have, if patients present with acute MI, they don't demonstrate clinical signs of heart failure, they look like their EF is relatively preserved or just mildly low, there's no evidence, no indication that we should have early treatment with aldosterone antagonists. And, perhaps when we have early reperfusion and we get there early enough before systolic dysfunction develops, overall, perhaps the RAS system does not get activated like we initially feared, and patients, just from that early intervention do a whole lot better, which we, I think, know from other trials that are not just looking at the RAS system. And then, I won't go over this, but I just wanted to summarize sort of the major trials that we talked about and just give one-line summaries of all of them. I'll just leave this here for a second for you to read up, and maybe we'll do questions at the end, since I think it's right at 8 o'clock for Jeff to take over.
All right, thank you guys. Thank you, Melroy. And I'm presenting a secondary analysis today. It's called the Hemodynamic and Metabolic Effects of Micro-Axial Flow Pumps and Infarct-Related Cardiogenic Shock. It's a secondary analysis of the DANGER trial. No disclosures. So overview, we're going to spend probably more time on the background and the DANGER shock trial overview, because I think that's kind of where it really frames the importance of this secondary analysis. And then we'll talk about what methods they use in the secondary analysis. The results and the conclusions should be relatively quick. I usually start off my presentations with cardiogenic shock about there's really no universally accepted hemodynamic definition of cardiogenic shock. It's an easy concept, meaning that the metabolic demands of the body are not able to be met by the cardiac output of the heart. And I still like the definition that Dr. Hockman put in her 2001 shock trial, which is hypotension, and then you need to have impaired perfusion. And then in that trial, everyone got a PA catheter. Their index was less than 2.2, and you needed a wedge greater than 15. However, all cardiogenic shock are not alike, and recently there's been more stratification into the types of cardiogenic shock. And the two main types that are being researched today is the AMI, or the acute myocardial infarction cardiogenic shock, and then the heart failure cardiogenic shock. And the difference is the AMI cardiogenic shock typically starts off, as the figure on the left shows, the patient starts off at ambulatory, and then an insult happens and they go immediately to cardiogenic shock. Whereas heart failure cardiogenic shock starts off ambulatory, and over the course of maybe 3 to 5 years, after multiple hospitalizations for acute decompensated heart failure, and then eventually will become heart failure cardiogenic shock as well. There are a couple of other cardiogenic shocks that aren't captured by these two, and the major one that comes to mind is valvular cardiogenic shock. So the one that we'll focus on today, obviously, is AMI cardiogenic shock, hence the title of the paper. And the incidence of AMI cardiogenic shock is increasing, at least per the national inpatient sample. So you can see on the left figure here, both of these papers used a national inpatient sample. The blue one is overall cardiogenic shock. And you can see that at least in the national inpatient sample, it's being driven mainly by the non-AMI cardiogenic shock, which would be the heart failure cardiogenic shock. However, AMI cardiogenic shock is increasing as well. And then the figure on the right, also from the NIS, shows that among patients who were admitted with a ST elevation MI, the prevalence of cardiogenic shock is increasing as well. Probably a nod to the fact that we're taking better care of our patients, they're living longer, and so if you come in with a STEMI and you're older, you're more likely to be in cardiogenic shock. Along with the increase in cardiogenic shock is also the increasing use of Impella. And so this paper also used a national inpatient sample. And from 2012 up until 2017, you can see that the proportion of patients getting Impella with AMI-CS has also dramatically increased by fourfold just during that 5-year period. So even though there's been, dramatic increasing numbers, increasing use of Impella, I still like to go back to pathophysiology, and this is Dr. Hockman's review after she published a shock paper in which she shows the cascade of how an acute myocardial infarction leads to death. And so it's kind of a busy slide, but really there's only been two main areas that we've been treating in the last 20 years. And the first is the acute coronary syndrome. So it makes a lot of sense to go after the nidus, or the start of the entire cascade. And then the second part that we've been treating is the circulatory failure. And so the acute coronary syndrome, when you treat it, we all know the saying that time is muscle. And then the circulatory failure is really everything else. It's preventing the multi-system organ failure. And there's really only three main treatments for these main pathologies, I would say. And it's PCI, number one. Number two is inotropes and vasopressors. And then third, the newcomer, is mechanical circulatory support. So the way I frame these in my brain, and I'm happy to hear other people's opinions as well, but the way I think about PCI is that it's not really a treatment for circulatory failure. It's really a treatment for the muscle. It's really the treatment for the acute coronary syndrome. And eventually, if you increase the contractility, you may increase the cardiac output. But the main idea of PCI is to save muscle. The second treatment, inotropes or vasopressors, really is to treat the circulatory failure. It does nothing for acute coronary syndrome. In fact, it makes the myocardium, it's toxic to myocardium, and it will actually increase the infarct and ischemic size of the infarct. So inotropes and vasopressors are actually toxic in the setting of AMI cardiogenic shock, but in the setting of circulatory failure, multi-system organ failure, it's almost a lesser of two evils. And I think that's why MCS has been very attractive in the last 20 years, or 15 years, I would say, because it is not supposed to be toxic to the myocardium. It does have many other side effects, and complications, but being cardiologists, we worry about the heart, and we know that MCS can actually improve the cardiac output, so it will prevent multi-system organ failure. And there's even some research now talking about LV unloading and how it actually helps preserve myocardium. And I think this is why the Danger Shock trial was such a pivotal trial, because it was really the first trial that showed MCS was beneficial and had a mortality benefit. All other MCS trials, from ECMO trials to even the 3 previous Impella trials, really showed that there is no mortality benefit. They did show some hemodynamic benefits, but it's always been hard to narrow down that population where patients had a mortality benefit. So this was published in 2024. I'm not going to rehash this trial in its entirety. It was presented at the ACC scientific sessions. And then also of note, it will use the Impella CP, not the 5.5. It enrolled, I think, like starting in 2013 or something, so the 5.5 wasn't even a thing then. And so I'm going to spend about 3 to 4 minutes talking about the Danger Shock trial, because obviously this is a secondary analysis of the Danger Shock trial. But I think we all know the punchline is that it did have a mortality benefit. And so what they did was they included adults with ST elevation MI in cardiogenic shock, and you needed to have all three of the inclusion criteria. Your blood pressure needed to be low, or you needed to be on vasopressors or inotropes. You had to have a lactate of greater than 2.5, and you had to have a documented EF of less than 45%. And I think that the exclusion criteria highlighted in red is critical because there was a previous MCS trial done just about 2 years ago called ECLS shock that was done in Europe as well, and they included GCS less than they included out of hospital cardiac arrest, and over here they excluded out of hospital cardiac arrest with poor neurological status, and I think this was a key reason that they're selecting patients that are sick but not so sick that they won't benefit. And then they also excluded acute valvular pathology and RV failure, randomized 1-to-1, and then they used Impella 2.5 or CP, and they ran it at P9 for 48 hours. And then TMCS was not recommended but allowed. So basically, in the control group, it was considered like a protocol violation if you went to TMCS, but they allowed it. They didn't say you couldn't do it. It was just considered a protocol violation. And then essentially all patients got PCI, the culprit vessels, and got inotropes or vasopressors titrated to their hospital standard. And this is sort of their consort diagram, essentially 180 and 180 in both arms. And then there were some patients, families that denied consent. And so the intention to treat is 176 to 179, which is what they used. And then again, I kind of want to highlight the key exclusion criteria that they're comatose after out of hospital cardiac arrest, which is essentially a third of the exclusion. So they actually screened 1,200 patients, and about a third of those, about 400, were excluded for out of hospital cardiac arrest. So I think this might be a key exclusion criteria going forward. And this is sort of the punchline is that from the DanGer trial that Impella reduced 6-month mortality compared to standard care alone. And the reason this paper was published is because now they're trying to figure out, well, why did Impella reduce mortality? And so this is what I'm going to try to dive into. And so their hypothesis, which is a very reasonable one, is that Impella CP and AMI cardiogenic shock reduced mortality by increasing cardiac output, and this resulted in reduced need for vasopressor and inotropes, and then also improved tissue perfusion. And so the way they're going to measure vasopressor and inotropes is they used two scores that I'll go over briefly that quantifies the amount of vasopressors and inotropes, and then they also quantify the hemodynamics as well. And then they're going to measure tissue perfusion by lactate. So again, all very reasonable things that we would consider. And then so they use something called a vasoactive inotropic score, a VIS. And I don't. This is definitely more of a research tool rather than a clinical tool. So I think it's important that we just kind of understand it, because that way we know what they're using to what type of yardstick they're measuring. And so basically they got the vasopressor score, which they added was dopamine. Then they considered epinephrine in the vasopressor score. I know we don't normally do that, but we know there is some vasoactivity to it, and it's not just inotropic, but they considered it under the vasopressor score here, and then norepi as well. And so basically dopamine, they're all 3 in mics per kg per minute. And then, as you know, the epi and norepi is usually like decimals, like point something. So they multiply by 100, and that's your vasopressor score. You add 3 numbers together. And then the inodilator score, they included dobutamine, milrinone, and levosimendan, which is mainly used in Europe. And then the conversion from milrinone was times 10, which seems a little bit, I want to say, it didn't seem what I typically thought the conversion, but they seemed to think it was fine, and it was published in another paper as well. And so, for example, if you had a 68-year-old man who had a STEMI and he was on dobutamine 5 and norepinephrine 0.1, then his vasoactive inotropic score would be 5 from the dobutamine and then 10 from norepinephrine. And then for someone similar on dobutamine 5, milrinone 0.25, and norepi 0.15, 5 of dobutamine would give 5, and then 0.25 of melanoma would give 2.5, and then norepi 15 that give the VIS score of 25. And then after that, they then used the vasoactive inotrope score and added it to this one, which they called like clinical marker score, it was a mix of heart rate, blood pressure, and lactate. And then so basically they had some not arbitrary, but just some cutoffs here about how many points you would get. And basically the higher heart rate, the more points you get. The lower your blood pressure, the more points you get. The higher your lactate, the more points you get. And then the higher your vasoactive inotropic score you get, the more points you get. And long story short, the higher your score is, the higher your severity of shock. So high score is bad, low score is better. And then this paper actually buried the data. I don't know why they did this, but they buried the data in a supplement in a table format, which was very not helpful. So I actually just took the numbers out and put in an Excel figure on the next slide, you'll see. So this is the vasoactive inotropic usage in both groups. And so you can see that the Impella group is green, the standard group is orange. And I thought this was a little interesting, but the authors do explain it. So at baseline, there's no difference between them. They didn't give us the numbers for the baseline, but it would be before 0. And 0 is when they hit the ICU. And that once they hit the ICU after the Impella is placed, the amount of vasoactive and inotropes needed is lower in the Impella, and it remains lower up until about 24 hours. And so the author sort of explained that there might have been some survivor bias because maybe the sickest patients in the standard groups died, and then you were left with a less sick group of AMI cardiogenic shock. And then they explained that the Impella continued to rise after 24, 48 hours because at that point they're trying to wean. I guess I remember the method said it should be 48 hours for full support. So, it doesn't quite make sense, but the authors did say that maybe they're trying to wean the Impella, and that's why they had to go up on the inotropes. But essentially, in the first 12 hours, there was more vasoactives and inotropes used in the standard of care group, and so Impella did reduce the amount of toxic vasoactives you needed. Now, the next one is looking at the heart rate and the blood pressure. You can see that the heart rate was essentially the same, and the blood pressure, no major differences. And I think that the blood pressure I expected because obviously we titrate these things to a map. The heart rate was a little unexpected to me because, we don't normally titrate things to a heart rate, but either way, they're both not different. So then the last metric we're going to look at is the lactate. And so the lactate in the Impella group, they did give us the numbers at baseline. The Impella and the standard group at baseline was unchanged. I put it on the text on the right. Standard group was 4.5, Impella is 4.4. But as soon as I hit the ICU, you can see that the Impella lactate group is significantly lower. They did have confidence intervals. I didn't put it in. I couldn't figure out how to put it in Excel. But the confidence intervals didn't overlap for the first 3 hours, and then they did overlap later, but you could see that it's clear that the Impella group is lower than the standard of care group. And so then they used that vasoactive hemodynamic score. This is the one that they put in the main paper. And this one combined basically the vasoactives, the inotropes, the blood pressure, the heart rate, and the lactate all into this one like mega score, so to speak. And you can see that the micro-axial flow pump, or the Impella, was lower up until maybe about 24 hours, whereas in the standard of care group, it was higher. So the way that I guess you can interpret the score is that there's less support to maintain a certain heart rate, blood pressure, and lactate for the Impella group. And so this lower score was driven by, or I guess the higher score for the standard of care is driven by more vasoactives and higher lactate. And so I'm kind of wrapping up my presentation now because this is pretty much all the main data. But, I think this is not surprising because we know that Impella does increase cardiac output. Exactly how much it increases, I was curious, and there was actually this 2008 paper. I think it's the Impella stick trial, I think, but it was a randomized clinical trial, and they did use thermodilution, and essentially Impella CP increases your cardiac output by about 1 liter per minute based on thermodilution data. Doesn't do 2.5 But I think but it does unload the heart a little bit. So, what the heart was theoretically pumping out before, it pumps out less. And the Impella, while it increases the net from 3 to 4, it's probably doing a bigger share than we think of just 1 liter more. It might be doing 2.5, but it's not additive to what's existing already. And I think that makes sense because when you look at the PV loops, you're decreasing the preload of the LV. So in the bottom right, I put just a basic PV loop of what the Impella does, and so it's actually making the heart work less. So I think sometimes, at least when I used to think about Impella and they said 2.5, I would think that it added an additional 2.5, but I think it's a little more complicated than that. It adds a little more, but more importantly, it unloads the heart. All right, last slide. So in patients with AMI cardiogenic shock, Impella CP reduced 6-month mortality. That's per the DanGer shock trial compared to standard of care. And then the next 3 bullet points is really what the secondary analysis is all about. Impella placement is associated with reduced vasopressor and inodilator usage in the first 12 hours. And so maybe it's the toxicity from these medications and reducing the amount needed that is improving the mortality. Impella placement is associated with improved tissue perfusion in the first 6 to 12 hours by lactate, and these differences may be the mechanisms by which Impella reduces mortality. All right, thank you guys very much.
Thank you to both of you. Do we have any questions from the crowd?
Yeah, this is Neil Dickert. So just a quick sort of question about the subgroup analysis, or not subgroup analysis, secondary analysis of DanGer data. So one super minor thing related to the older trial from 2008, that the 2.5 device is an old device. We don't see much anymore, but that actually is a device with less. It isn't the same in terms of flow as the CP. So it's a smaller device that does provide a little less support. So that may be part of it. The other piece is obviously when you're measuring output, there's an interesting question about sort of what it does to increase the output versus what it does to decrease the component of the output that the heart has to generate, right? So you probably have some compensatory loss from something that's overcome. So it's hard to measure in terms of direct supplementation and how much it's producing. That may be that translation may not be exactly the same. That's a sort of minor point. I guess the bigger thing I would be curious. It seems to me I'm curious about the notion of attributing good outcomes to absence of vasoactive medicines, as opposed to, it seems to me what the most persuasive change was that you just provided better perfusion earlier in terms of reducing lactate and whatnot. So you reduce your likelihood of causing a cascade of end organ failure. I'm curious as to whether you think that the sort of mechanical support, the people who really buy into it strongest will often talk about toxicities of vasoactive medications. It seems to me that the most persuasive thing is you just got better perfusion earlier.
Yeah, that's a great point. And I think that if we wanted to kind of answer that question more fully, like I wonder if they could do sort of like a cause of death analysis, because right now a mortality is a mortality. We don't know exactly why patients died, because obviously they have that data set on lock and key. And so it would be interesting if maybe like the cause of death were like from cardiac versus non-cardiac causes. And I guess one way to answer that question would be if they're going to do another secondary analysis, if there was more non-cardiac causes of death. I don't know if that would help or not, but I feel like understanding your question correctly, we're talking about maybe like multi-system organ failure not related to the heart. So if they had more non-cardiac causes of death in the standard of care, that might answer the question. Is that kind of what you were kind of thinking about?
Yeah, I mean, I think it seems to me the two things you want to know, ideally, would be end organ failure and other causes of death, and then myocardial recovery as a function of early unloading, right? Those are really the two, and I think I do think it's a separate thing to say to attribute it to reduction in vasoactive medications versus beneficial effects of, increased support and earlier unloading. Those two things may or may not necessarily go together.
I agree. I totally agree. And I think they're two different pathologies. And like, whenever, when we're presenting a problem list for these patients, we should be focused on therapies tailored to both of those pathologies.
Jeff, Stan Sherman. I was just wondering the criteria to remove the Impella. Was the criteria to just remove it the same in both groups, or and did that affect things?
That's a great question. I know they have they had a recommended protocol for how to manage the Impella, and I don't remember if they had like a particular threshold level at which the Impella was taken out or not. But we can see here clearly that the inotropes and the vasoactives were going higher in the Impella, and so they were probably starting to wean at this point, the Impella, and at the cost of going higher up on the vasoactive. So long story short, I can take a look at their study protocol. They had in the original New England Journal paper, they did have a long 90-page study protocol that they looked at, and I can take a look at it and see if they have a specific weaning protocol or not. And obviously the standard of care group, I didn't present the data here. Let's see, I might have some of it, but only about, I would say about like 25% of the standard of care group got not randomized, but only about 20% of the standard care ended up getting MCS. So they did try to minimize it. And I would suspect that between the two groups and the ones who got the Impellas, it'd be about the same. So I don't think there's any differences in the weaning strategy because there's nothing about that. But I'll take a look in the protocol section to see if they had a specific weaning protocol.
Hi, good morning. This is Mahmoud. Sorry, my voice may be a little unpresent today. However, a quick comment on Melroy's presentation about spironolactone. And I really support your theory of the latter, where you said that probably it's the heart failure that signals RAS, not the other way around, and therefore you're seeing benefits in patients with acute myocardial infarction who have heart failure rather than the other way around. So I wasn't really surprised by the clear study results. Now back to Jeff. And Neil, you highlighted a very, very important point, exactly what I was gonna highlight. And actually, Jeff, go to your slide that shows the pressure volume loops when you put an Impella in. Because if you understand that one, if you understand this and analyze this pressure volume loop, you will really kind of have a good explanation of why the DanGer trial was positive. And, to Neil's point, I think a lot of people, when they think about mechanical circulatory support, they only think in a linear way about increasing the cardiac output, and that's it. I mean, the more cardiac output you have, the better the outcomes you get. And that's not necessarily just the whole picture. I think there's a lot to that story. We know from Bill O'Neill's work just before the pandemic and from the National Shock Registry Initiative and stuff like that, with unloading of the left ventricle, there's a lot of signaling that happens on the molecular level and the hemodynamic level that is probably the main reason why micro-axial flow devices have shown benefit compared to other traditional like historical mechanical circulatory support devices like the balloon pump, for example. So, there's a lot to do with that. And I totally agree with Neil's point. I think the positive effects of the Impella in acute myocardial infarction shock is probably, a lot of it is driven by, yes, improvement of cardiac output and unloading of the left ventricle and all that comes with it. And I mean, I don't think that the part of using less medicines or less drugs probably plays a small little portion of it, but not necessarily a big significant one. So very interesting. A lot's going to come out of the danger study. You'll see a lot of publications coming out. It's triggering a lot of it's the first clinical control trial that has supported what we thought a long time ago. So that's why it's going to be the highlight. And like you said, Jeff, it's a pivotal trial. So good job, both.
Thank you, Dr. Abdul.
I just add one minor thing just as a methodologic point for everybody that I think is really interesting. And Jeff, you got at this a little bit.
Mm-hmm.
You know, in the context of shock trial, I was in a meeting at FDA yesterday talking about a lot of these issues related to particularly related to mechanical support in this context. It is a really difficult challenge to deal with the survival bias problem when you have high mortality conditions like this. And it's particularly the case because, as many of you know, one of the sort of tension that came out of danger was you had a mortality benefit with mechanical support, but obviously they stacked up complications related to vascular access, bleeding, limb complications, and renal failure.
Yeah.
But renal failure in particular is incredibly difficult because people who are dead obviously don't go on dialysis, and people who are dead don't have limb complications. And so figuring out things like this and sorting out what's due to people being alive versus dead, what's due to kind of weaning process and whatnot. Some of those are relatively straightforward. Some of them get really difficult to sort out. And so I just encourage everyone as they're looking at this literature, just to remember how complex it is to kind of sort out what signals you're getting just because people are still alive, what signals you're getting that actually are attributable to the device or not. It's particularly is important when they're looking at one of the signals was obviously in dialysis and renal failure, and that's probably the most complex one to sort through.
Great point. Thank you, Dr. Dickert.
All right, well, we are right at the hour, so we'll end here. Happy weekend, everybody, and we'll see you next week.
The preceding program is copyrighted by Emory University.